Thanks, Kundan. Yeah. Yeah. Welcome to this pleasant evening. I'm Nakul Patil, Senior Product Manager.
Yeah.
And we at Emcure Inventia Division, Orofer FCM is our core brand and epitome of quality and success. Today, Emcure team is honored to have esteemed speaker to discuss about management of IDA in pregnancy. That's we are getting newer insights about the management of IDA in pregnancy. Now, may I take this opportunity to introduce today's expert, Dr. Parag Biniwale from Pune. Dr. Parag is senior consultant obstetrics and gynae in Pune. He is a president Pune Obs and Gynae Society. He was a vice chairperson in ICOG in 2021-23. And he was a national, currently is also working national webinar editor for the FOXY. He's a president for the Menopause Society in Pune. And he was a national joint secretary for the IMS 2017-18. We are very thankful for giving us opportunity to host this webinar, scientific webinar, and be a partner for this wonderful academic initiative, educational initiative. Today, Dr. Parag, rightly I have mentioned, Dr. Parag is sharing his views on management of IDA in pregnancy. I want to highlight one thing over here to all delegates. If you have any questions, any doubts, question and doubts during this session, please put your questions in chat box. Surely our expert will address once the session get over. Once again, welcome, Dr. Parag, and over to you.
Thank you. Good evening. I bring greetings from Pune, and it's indeed a pleasure to be talking to you all about a very common problem, and that's iron deficiency anemia. Let me thank Team Emcure for arranging this and asking me to share my thoughts about iron deficiency anemia. All of us are aware that WHO has defined anemia when the hemoglobin is below 11 grams percent and the hematocrit is less than 33%. As far as our country is concerned, we are very happy if the hemoglobin of a pregnant woman is at least 10 grams percent. So for our country, we accept 10 as the limit, but it is better that we should have hemoglobin of more than 11 or ideally more than 12 grams percent. Of course, ICMR has then classified the degrees of anemia into mild, moderate, severe, and very severe. Why we are talking about iron deficiency anemia? Initially, we always faced, for last 50 years, 60 years, we've faced issues related to anemia and iron deficiency in particular. There was a certain improvement for a relatively good amount of time, but over last 5 years, it is noted, and then the Ministry of Family Welfare and Health has very categorically stated that anemia is again rising. And that is the reason why we are going to have some discussion today here. So iron deficiency anemia by itself contributes a lot to maternal death. We know there are so many causes of maternal deaths, which include hemorrhage, obstructed labor, sepsis, hypertensive disorders, and anemia, of course, contributes to about 8% of them. We know the causes and we know the consequences also, because low dietary iron intake is something which really is a big challenge. Poor absorption of iron. Unfortunately, we as Indians absorb iron poorly. Malaria, hookworm infestation, high fertility. Typically, multiparous, we do get multiparous patients with repeated frequent pregnancies. Other micronutrient deficiencies, especially folic acid and B12. And let's not forget a big foray of infectious diseases. And of course, maternal anemia, apart from increasing maternal and perinatal morbidity and mortality, there are increased number of preterm births or low birth weight babies, impaired cognitive development, and reduced work productivity. So when we talk about anemia, there are two aspects to it: a physiologic anemia, which can happen to each and every pregnant woman, and pathological anemia, which needs urgent attention and treatment. Because of the physiological changes in pregnancy, where there is hemodilution, uh, there is decrease in the blood viscosity, the increased blood volume usually leads to a fall in hemoglobin, and it could be as high as 2 grams percent. So this is something which is likely to be present in each and every pregnant woman. But what we are worried about is the pathological anemia, and we know the contributory factors. There are dietary deficiencies, anemia being the most common, seen in about 60% of deficiency anemias. Folic acid B12 deficiency, which typically leads to macrocytic anemias, that is seen in about 10%. Dimorphic anemia is seen in about 30%, where the woman is deficient in iron as well as folic acid and B12. In cases of extreme malnutrition, there could be additional protein deficiency, which adds to the problems of the pregnant woman. There are certain hemorrhagic situations where there could be acute blood loss or chronic blood loss in the form of piles and hookworms. Let's not forget hemoglobinopathies, and this is something which all of us should try and diagnose in the early part of pregnancy, or ideally preconceptionally. Anemia because of infections and chronic diseases is a known entity, and very rarely we do come across women with aplastic anemia. When we talk about anemia, it practically impacts the pregnancy in the antepartum period, in the intrapartum period, and the misery continues even in the postpartum period. So we do get to see more number of abortions, infections. Preeclampsia and APH are somehow common with anemia. Severe anemia may land up in cardiac failure. In intrapartum situations, there is a possibility of uterine inertia leading to dysfunctional label patterns, increased risk of instrumental delivery. Fetal distress is something which is known, and women tend to develop cardiac failure and shock much more commonly. The problems continue in the postpartum period, because here we have to deal with puerperal sepsis, thromboembolisms, delayed wound healing, failing lactation, and of course, subinvolution of the uterus. And of course, there are effects on the fetus. We do get to see more of growth-restricted feti. Prematurity is a known thing. There is increased risk of iron deficiency anemia in early pregnancy or infancy. Conj malformations are known. We do get to see stillbirths or intrauterine fetal demise, and increase the risk of neonatal death and perinatal mortality. But the effects on the neonate is something which is not so commonly discussed. Here, I would like to point out that iron deficiency and iron deficiency anemia adversely affects the fetus and neonate, adding to its morbidity and mortality. So typically, the neonate is seen with abnormal hematological parameters. There are changes in anthropometric, which are noted in women with anemia. And very importantly, we do get to see anemia impacting the fetal neurodevelopmental disorders, which include intellectual disability, autism spectrum disorder, and attention deficit hyperactivity disorder. So this is something which many a times forgotten by us clinicians. Of course, there is an increased risk of cardiovascular diseases in the offspring, and possibly risk on renal system, thyroid function, and even immune function. All these factors would tell us that we need to be very, very aggressive when we diagnose a pregnant woman with anemia. So we need to find out what is going on, and we must try and pinpoint the cause and treat it as early as possible. All of us are aware about the symptoms of anemia. The pregnant woman will, of course, complain of palpitation, dizziness, lightheadedness. Her working capacity reduces. She may give us history of fatigue, weakness, pica, and dyspnea on exertion. There are, of course, some clinical signs which will tell us that the woman is likely to be anemic. So there would be a pallor depending on the hemoglobin level, glossitis, stomatitis, more noted in folic acid and B12 deficiency, platinikia or koilonychia. The woman may have tachycardia, ejection systolic murmur. Edema is something which is noted at times, and postural hypertension is pretty common in these women. So when we talk about prevalence of iron deficiency anemia in pregnancy, please remember it's a global problem. It is seen in all countries. In general, etiology of anemia is attributed to iron deficiency. And as per Global Nutrition Report 2016, India ranked miserably at 170th in terms of anemia prevalence in women. And this is something which we as obstetricians and gynecologists must take very, very seriously in order to diagnose, prevent, and treat anemia in pregnancy. And iron deficiency is something which should be considered as a major issue, because by the time there is a serious iron deficiency, the iron stores are more or less depleted. And the RBC iron also goes down to a minimal level. We know the iron demands that increase in pregnancy. So in general, there is a need of 630 milligrams of iron throughout the pregnancy, and we hope that we supplement it in the form of diet or in the form of medications. It could be oral medications or even parenteral whenever the need arises. There are, of course, parameters which will tell us about the iron status. Serum iron is something which will be the value of which will reduce in almost all anemia. So it would reduce with iron deficiency anemia, or even anemia of chronic diseases. But ferritin is something which is really peculiar to women who have iron deficiency and iron deficiency anemia, and that is something which we have to keep in mind before advising certain investigations in these pregnant women. So in whom we should be doing serum ferritin testing. Now, prior to starting iron therapy in therapeutic doses in patients with known hemoglobinopathies, because we don't want them to be overloaded with iron, when an alternative etiology of microcytic anemia is being considered, where we are looking at a possibility of chronic inflammation-led toxicity or sideroblastic anemia, suboptimal response to oral iron when compliance is doubtful, in non-anemic women at increased risk of iron depletion, such as those with previous anemia, multiple pregnancy, teenage pregnancy, etc. In women who receive therapeutic iron therapy for about 8 weeks when non-anemia iron deficiency is being treated, and preferably prior to parenteral iron therapy to confirm iron deficiency and the status of iron stores in the body. So how do we approach a case of anemia? First and foremost, universal screening for iron deficiency anemia with hemoglobin is a must, and it should be done in the first antenatal visit itself. Ideally, we should be doing a complete hemogram for a woman who comes to us prior to conception for preconceptional counseling. And here, many of us are recommending testing for hemoglobinopathies like thalassemia or sickle cell disease, which can easily be diagnosed preconceptionally. So if the hemoglobin rise doesn't take place in about 2 weeks, we may have to think of doing further investigations. And this is something which has to be really treated critically, especially when we are noticing that there is iron deficiency which is not responding well to the treatment. So when we talk about workup, of course, detailed history is extremely important. Dietary history, all of us have been taught in the medical colleges how important it is to ask for a dietary history so that we really can calculate the amount of calories, the amount of iron that she's taking. Ask for history of worms in stools, bleeding per rectal, hematuria, chronic diseases like TB, malaria, and even history of repeated blood transfusions. Physical examination is a must, and it will be a good pointer as to what type of anemia it could be. So if we get to see a splenomegaly or jaundice, then we know that we are dealing with a hemolytic anemia. Purpura will be seen if the anemia is seen along with bleeding disorders. Leg ulcers are typically noted in women who have sickle cell anemia, and there could be neurological deficit in women with megaloblastic anemia. Coming to the investigations, as I mentioned earlier, complete hemogram is a must, and we have to look at the red cells indices very, very critically, because they will exactly tell us what is going wrong with the patient. And of course, the reticulocyte count will tell us about the bone marrow activity. The newer RBC parameters are really important for iron deficiency anemia, because here the hypochromic microcytic or presence of reticulocytes will tell us about the status of iron deficiency anemia, and it may also help us in differentiating iron deficiency anemia from beta thalassemia trait. Other investigations may be offered as and when required. Let's not forget stool examination, or even bone marrow examination is something which is required when we are dealing with a woman who has refractory anemia, even in pregnancy. Coming to prophylaxis and treatment. When we talk about our Indian diet, we know that typical vegetarian Indian diet contains large quantities of inhibitors. We do consume non-heme iron from cereals, pulses, vegetables, and fruit, but in general, our diet is plagued by low iron content and poor absorption. So the National Nutrition Monitoring Bureau survey shows that the intake of dietary iron is grossly inadequate in most of the states in anemia, meeting less than 50% of what is recommended dietary allowance for our population. Right, and these are some suggestions which, as far as the diet is concerned, and this is something which we as obstetricians must give to our patients. They have to have at least 3 meals, try not to skip meals, and rely on foods rather than vitamin supplements for good nutrition. So these are the foods which are rich in iron. Let's not forget foodstuffs which are rich in vitamin C, because vitamin C is going to help in absorption of iron in our pregnant women. Whenever we are talking about diet, we should be aware about the enhancers and inhibitors. As I mentioned earlier, vitamin C or ascorbic acid is a good enhancer. It will absorb iron well. Heme in iron present in meat, fish, poultry, and seafood is a good enhancer. But then there are some inhibitors which can really pose a lot of challenge to us clinicians, which includes tea and coffee, calcium, antacids, proton pump inhibitors, and even some whole grain cereals which contain phytic acid. So this is something which we really have to keep in mind before we talk about dietary changes that are needed in the course of pregnancy. So these are some recommendations we all should keep in mind, that awareness and healthcare education strategies are really important, and we should try and encourage women to consume iron-rich foods and diet that enhances iron absorption. Daily iron supplementation, 60 to 100 milligrams of iron and folic acid is recommended for non-anemic pregnant women. Usually, though it is recommended from the first antenatal visit, we usually start it in the second trimester. And women who have mild to moderate anemia and who do respond to a trial of oral iron, the treatment should be continued with 100 milligrams of elemental iron and 500 micrograms of folic acid, with a periodic assessment of hemoglobin levels. Repeat hemoglobin is usually recommended after 4 weeks of oral iron, and after achieving normalization of hemoglobin, a prophylactic daily iron supplementation is recommended at least for 6 months during pregnancy and should be continued in the postpartum period for another 6 months. So parenteral iron does have its own role in pregnancy. So it is recommended for women with anemia who do not respond or are intolerant to oral iron. And among the newer intravenous formulations, iron sucrose, in fact, is supposed to be the first which was approved for use during pregnancy, but it is not to be given in the first trimester. Parenteral iron is also recommended for pregnant women with severe anemia, where rapid restoration of iron stores is required. So, women in the second and early third trimester with severe anemia, the first drug of choice or the first medication of choice is parenteral iron. Packed red blood cells have its own place, especially when the cardiovascular health is compromised, and deworming is something which should be clearly recommended. Coming to iron therapy. So oral iron therapy, there are certain indicators how we find out whether whatever we are supplementing the pregnant woman is helping her or not. So feeling of well-being, improved look of the patient, better appetite, and rise of hemoglobin 0.8 grams per deciliter per week. And this typically starts after 3 weeks. In some women, there may be a failure of response, and here we may be dealing with a woman who has other deficiencies like folic acid and B12, or we may be dealing with a woman who has undiagnosed thalassemia. There could be faulty absorption or coexistent infections or even continuous blood loss, which needs to be investigated. Coming to various preparations, and when we talk about various iron preparations, the consort study, which was published in 2021, talks about a comparison between 4 molecules of iron: sulfate, fumarate, ascorbate, and carbonyl iron. And what was found out was there is no significant difference in all the 4 groups. So here, the hemoglobin rise was found to be more or less the same. In 2018, the government of India came with a document called Anemia Mukt Bharat, where it talks about treating anemia rather aggressively. So if you are dealing with a woman who has mild to moderate anemia, we should be offering her higher doses of iron and folic acid. And of course, parenteral iron may be considered as the first line management in pregnant women who are detected to be anemic late in pregnancy or in whom compliance is likely to be low. If there is no improvement after oral iron, then ideally the patient should be referred to a higher health facility, and here injectable iron can certainly be offered to her. And when the anemia is severe, injectable iron is the treatment of choice, and this has to be offered to a patient, especially after hospitalization. So that brings us to the indications for parenteral iron therapy. So typically, we are using it in women where there is failure of oral iron therapy. You prescribed iron, the patient is taking it well, but somehow the hemoglobin rise is not taking place. Or if the patient is non-compliant, she's not taking iron therapy well, or if she's intolerant to oral iron, we can certainly consider parenteral iron therapy. Rapid rectification of anemia and repletion of iron stores when it is expected. Malabsorption when women who've undergone bowel resection or celiac disease, and bleeding diathesis where hemorrhage is likely to continue. But of course, there are some situations where we will not use parenteral iron therapy, and that includes early pregnancy before 12 weeks, because we really don't know whether the injectable iron will have an impact on the baby. Lack of facilities for resuscitation, known history of anaphylaxis or reactions, and known state of iron overload. So if we are dealing with a thalassaemic woman, we need not supplement her with injectable iron therapy. So IV iron therapy is superior to oral iron in terms of speed and absolute extent of rise in hemoglobin, and very importantly, replenishment of iron stores. Coming to the evolution of parenteral iron therapy. Now, iron therapy is something which is in vogue for many, many years. In fact, if you look at the slide, you will realize that intravenous ion therapy is there for almost more than 3 decades. And the new kids on the block include ferric carboxymaltose, which was launched in the year 2013, and the recent one is iron isomaltoside. When we talk about parenteral ion, the structure of iron carbohydrate complex is important because this is going to allow administration of large doses of IV iron in the complete replacement dose in a single dose in a short duration of time, and that too rather safely. So when we talk about parental ion preparations, they are typically classified depending on the type of complex, and the type 1 complex, which has a strong thermodynamic property, are the ones which are in vogue nowadays, which includes ferric carboxymaltose, and the type 2, which has moderately strong thermodynamic property, that is iron sucrose, has also been being used for anemia in pregnancy. So these are the 3 generations of parenteral ions. Many of us have used iron sucrose and are still using it. And the 3rd generation now are here to stay, especially the ferric carboxymaltose. When we compare the properties and when we start thinking about which probably is the ideal parental ion, well, the answer is still unclear. But if you look at the slide rather carefully, we can say that we can give a robust molecule in a dose of 1000 milligrams in an infusion over a short span of 15 minutes, where we expect a low antigenicity, no need of test dose, and a short hemoglobin rise. There are, of course, limitations of parental ion preparations, which we have to keep in mind, especially iron dextran, which we used way back in the 90s, which were associated with serious allergic reactions. And here we had to have a mandatory test dose. I don't remember using iron dextran as an IV infusion, but these were the injections that we used to administer, which were really painful. There was a lot of staining in the skin, and there was a requirement of multiple injections. And the sad part was, in spite of those painful injections, we did not know whether whatever we are injecting will be absorbed or not. Then came iron sucrose, and it really changed the management protocol of iron deficiency anemia in pregnancy. But remember, multiple clinical visits are required because it can be only administered in low doses, not more than 200 milligrams a day and not more than 600 milligrams a week. About the 3rd generations, I personally do not have any experience with iron isomaltoside, which does contain highest amount of labile iron amongst the 3rd generation parental ion, so which makes it more at risk for hypersensitivity reactions. So ferric carboxymaltose by far appears to be a robust and strong type of a molecule which can be administered in high doses in short duration of time with good tolerance. So we do require less frequent clinic visits, and the safety profile of FCM is really good. The iron content being high, there is rapid correction of anemia and repletion of iron stores, and in general, risk of hypersensitivity reaction or anaphylactic reactions are very, very low. So the test dose is not required, and FCM does offer excellent safety profile. So these are some of the qualities of FCM which are best suited for real life clinical usage, and the advantages being fewer clinic visits, safe administration of a high dose. It's a stable complex, so it does not release non-transferrin bound iron, low antigenicity, no test dose required, and structurally it is similar to ferritin, so it is deposited easily in the reticuloendothelial system. When we compare these four ions, we realize that carboxymaltose offers a high amount of iron in a single dose with low risk of hypersensitivity reactions. And how do we calculate the dose? This is the formula that we need to remember. When the hemoglobin is less than 10, depending on the weight, we decide how much iron to be given. How do we give it? If we are giving a dose of 500 milligrams, it has to be added to 100 ml of normal saline, and it should be given in a span of 6 minutes. And if you are giving a dose of 1000 milligrams, it should be added in 250 ml of normal saline, and the solution has to run within 15 minutes. Here, the adverse drug reactions of FCM are considered potentially related to long duration of infusion administration. So please ensure that it finishes in time. Dilution of FCM in high volume of saline beyond recommendation may lead to certain reactions. So we really have to be very, very particular as far as administration of FCM is concerned. And then there's a global evidence of safety and efficacy of ferric carboxymaltose in pregnancy. And this was a data which was published in 2018 and 19, which had over 5,000 women, and there was a hemoglobin rise of anywhere between 3.6 to 5.5 grams per deciliter, and of course, good rise in serum ferritin levels too. Coming to the Indian studies, and I must refer to this study by Charmila et al., which talks about efficacy and safety of ferric carboxymaltose, and this was a multi-center real-world study from India. It did have more than 1,800 patients. That's a good number. And what was noted was there were fewer adverse reactions seen. Mild adverse events like nausea, headache, diarrhea, constipation were noted. There was a good hemoglobin rise of about 2.76 grams percent, and serum ferritin levels of increased by about nearly 35 micrograms per liter. Another Indian study, which was published in the Journal of OBGYN International in the November 2022 issue, it also reiterates the fact that the hemoglobin rise was good, 2.8 grams per deciliter, with a good ferritin rise of about 30 micrograms per liter. This was a study from my own city where a single large dose administration of FCM led to a rapid rise of hemoglobin in moderate to severe anemia during pregnancy. And here, what was noted was a significant increase of hemoglobin by about 4.23 grams per deciliter was seen in women who had severe anemia. And this is something which really would be a game changer, because we know that women are still dying, and severe anemia is one of the big contributors. If we administer a simple drug like FCM, we are making the woman iron rich, and her status of anemia improves, and then she definitely has lesser chances of dying because of anemia related complications and postpartum complications, and we can save life of that woman who's delivering. Now, the same study did talk about different impact of FCM administration. So what they found out was all the vital parameters were within normal limits over the monitoring period of about 45 minutes. No clinically significant change in vital parameters during and immediately after FCM, and there was absence of any hypersensitivity reaction. So it reiterates the fact that it is a safe and tolerable drug for treatment of iron deficiency anemia during pregnancy. And there were no adverse effects in the term of perinatal and neonatal outcome were seen in newborns of women who received FCM during pregnancy. So there is a global evidence about the neonatal outcomes, and in general, it is noted that neonatal outcomes, that is a week of pregnancy or delivery, APGAR scores, birth weight, neonatal resuscitation, complications, etc., were not adversely affected due to administration of ferric carboxymaltose. And the FOXY 2017 GCPR does talk about parental iron, and it can be an alternative in mild to moderate anemia. Parental iron is also recommended in women with severe anemia, where we want rapid restoration of iron stores. And iron sucrose, of course, is the drug of choice, what was mentioned in that. And high quality studies evaluating safety and efficacy of ferric carboxymaltose in pregnancy should be performed. And now we can, of course, make a change in the GCPR, where there is a good amount of evidence that is available for us, for women during pregnancy. And of course, postpartum anemia, FCM, is the drug of choice, and it has always been the drug of choice for many of us. We must not forget treatment of related conditions, because malaria, hookworm infestations are something which are really important additive factors for anemia in pregnancy. So prompt detection of these conditions and treatment is extremely important. And these are some of the do's and don'ts which should be explained to the patient, where hygiene related issues should be considered for pregnant women. So whenever we are thinking of a safe mother and a healthy child, this is something which we really have to imbibe on. And by treating anemia aggressively, we will try and break this intergeneration cycle of anemia, because we know that an anemic pregnant woman will give birth to a baby with low iron and hemoglobin. The anemia many a times remains uncorrected in infancy and childhood. The girl grows up being iron deficient, and with the misery is added because of menstrual blood loss. And when these adolescent enters the reproductive age group, she already has low iron stores and then suffers during pregnancy as well. So these are some of the important strategies which we all have to remember about prevention of iron deficiency, anemia, and malnutrition. And it would include improved health services, dietary diversification, food fortification, and supplementation of iron folic acid along with deworming. And the National Iron Plus initiative is something which we should keep in mind, because here we are trying to prevent anemia in children, adolescent girls, women, young women of reproductive age group, and pregnant and lactating women. I must make a mention of Anemia app, and this is thanks to Dr. Gorak Mandrupkar. So this is a free app on Android app stores based on Anemia Mukta Bharat and Foxy ICOG GCPR on anemia. If you want to calculate dose of iron, injectable iron, this app will instantly tell you how to calculate it. So to conclude, iron deficiency anemia in pregnancy is readily manageable, yet an unmet health demand, and we have to take it rather seriously. The management strategy is dependent upon the period of gestation and severity of anemia. So whenever we are getting women who are severely anemic, they have to be under supervision, should be aggressively administered drugs like ferric carboxymaltose, where it would certainly be beneficial to her. Widespread implementation of preventive and therapeutic strategies is still lacking, and here we all collectively should put in our efforts to look after this. Organization of awareness camp, patient group meeting, etc., is really important to address this public health issue, using a pragmatic approach that combines the recent scientific knowledge with an empathetic attitude of medical fraternity to tackle this problem. The country can achieve the WHO 2025 global nutrition target of 50% reduction in prevalence of anemia in reproductive age group. And injectable iron, especially ferric carboxymaltose has an emerging role in management of iron deficiency anemia. Thank you very much. And
That's great, sir.
Oh,
Really great.
yeah.
I can say means it was a really wonderful session. Lot
Thank
of insights all members they got. Sir, happy to share with you this webinar attending more than 400 doctors across pan India. Sir,
Great.
yeah, sir. A few questions from delegates. First question I want to share with you that from Dr. Archana Chaugule. She's from Pune. She's asking, you mentioned EPSIM has no risk of anaphylaxis.
Right.
What about the iron sucrose?
Iron sucrose also does not have this problem. You see, we've been using iron sucrose for iron deficiency anemia for years. In fact, personally, I have started using FCM for last about 8 or 9 months. Before that, I had my own reservations because it was not approved by the DCGI, though there were a lot of people using it. I had my reservations. But after going through a lot of literature, I have started using it. But personally, iron sucrose is very safe. So is FCM. We've not had any kind of serious adverse events with any of these molecules.
Right, sir. Another question, sir, from Dr. Nikita Pawar. She's asking trimester-wise line of treatment, which is differs during pregnancy for IDA.
Okay. Now, see, typically in the first trimester, because women have nausea and vomiting, generally none of us are prescribing iron to them. So we try and advise them regarding improvement in the dietary iron intake. Now, typically, we always start oral iron supplement at around 12 to 14 weeks once the patient, the nausea vomiting status reduces. So first line therapy
Right.
essentially is oral iron. And then we keep on monitoring the hemoglobin level depending on the baseline level. As I mentioned in the presentation, that at the first visit, a baseline hemogram has to be done. And depending on the level, we decide how frequently this should be repeated. Now, in general hospitals like Sassoon and Kamla Nehru, we always repeat it every month because we get a lot of patients of the anemia in general. So we tend to do hemoglobin estimation more frequently. But depending on the baseline level, start oral iron, keep on monitoring it. And depending on the hemoglobin rise, depending on the tolerability, depending on the compliance, you decide whether to continue oral iron or switch to injectable iron.
Yeah, hope Dr. Nikita got his answer. Another question, sir, from Dr. Dhaneshri Lahane. She's from Aurangabad. She's asking the role of HB electrophoresis in routine ANC with anemia.
Okay. Now as I'm in a private practice, I do it for all. So we do it preconceptionally for all girls who come to us for preconceptional counseling, or even sometimes if they come to us for premarital counseling, we always tell them that this is something which should be done. Now, in Kamla Nehru Hospital, where I visit, we are not doing it in all patients. We are offering it to many. But in case of severe anemias or in case of moderate anemias, where the hemoglobin rise is not sufficient, and where if we have to administer injectable iron, before that we get them screened for thalassemia and other hemoglobinopathies.
Right, sir. Right, sir. Second, another question, sir. Many questions are there, but I'm picking a few questions. Dr. A.K. Lahan, he's from Purnia. He's asking up to what age for the thalassemia patient they can give FCM?
FCM?
Yes.
Why do you want to give FCM to thalassemic patients? Because see, in thalassemia, we are always worried about iron overload. So we usually don't advocate any kind of injectable iron. Well, in pregnancy, one may consider giving oral iron if required, if you feel that there is additional iron deficiency. But if we are dealing with a thalassemic woman with severe anemia where it could be additional iron deficiency, then only one can think of. But I have per se never administered FCM or even iron sucrose for that matter for women who are thalassemic.
Right, sir. Right, sir. Last question, sir. Question from Dr. Nishi. She's asking what happens if FCM be given for the longer duration, more than 30 minutes?
It shouldn't be given. It has to be over in 15 minutes.
Okay.
No, it's a basic principle that we have to remember, because in one of the slides I had clearly mentioned that if you prolong it, then there are more there's a theoretical possibility of free radicals being released and more chances of hypersensitivity reactions. So it has to be over within a span of 15 minutes, and that is how that is what we've been following. 250 ml normal saline and just start it, let it run in a at a very fast speed, and it should be over in 15 minutes, max 20 minutes.
Right, sir. Right, sir. Once again, thanks, sir. Really a wonderful session. A lot of insight we have got, and we are thankful for giving us opportunity to host this event, sir. Really, thanks, sir.
Thank you.
Thank you, Ravi, for arranging everything. And I would like to call our sales head to share his vote of thanks, sir. Over to you, Anil, sir.
Good evening, doctor. This is Anil Pillai here. I'm working as sales rep for division Inventia, and it has been such an honor to be a part of this wonderful event. And despite your busy schedule, on behalf of the entire organization Emcure, I would like to extend my heartfelt gratitude for your valuable time. I'm happy to share, sir, that it is around 400 doctors who are live with us, and once again, I'm sincerely thanking all the doctors who have patiently listened to Dr. Parag Guniwale for last 1 hour, and I'm sure it has benefited you a lot. And one thing, sir, a personal question from my side, that after announcement of government our Premium Mood Bharat guidelines, we have started using FCM in pregnancies. I would like just to have feedback of your usage in pregnancy, because you were not using till the announcement of government.
True. For years, it was not approved by the DCGI, so I had my reservations of not using it. But after going through the Anemia Mukta Bharat document and after interacting with people who used it in pregnancy and whose papers were published, I started using it, and we are of course using it in women who have moderate or severe anemia or anemia which is not responding to oral iron therapy, and it works wonderfully well. In our scenario, the hemoglobin rise is usually seen between 2.5 to 3 grams percent in a span of about 3 weeks. So that is what we've noticed. So whenever we have shortage of time, so if a pregnant woman is say at around 34 weeks or so, and here we want the hemoglobin rise rather quickly, I would prefer to use FCM rather than iron sucrose, because here we are pumping in 1 gram of iron in the circulation with a short hemoglobin rise of at least 2.5 to 3 grams percent.
Thanks for your valuable feedback, sir. But it was a big breakthrough when you told that I have started receiving pregnancy. It was a big breakthrough. It was a moment for us. We have been approaching you from last 1 year for pregnancy.
In fact, I started using it, and that's why I agreed to the lecture. Otherwise, I would not have given the lecture.
Absolutely, absolutely. Thank you for valuable time, sir. Your busy schedule, you could give this valuable time to the entire medical fraternity. And on behalf of Emcure, sir, thanks to all the doctors who are patiently listening, Dr. Parag Guniwale.
Yeah.
Thank you, doctor.
Thank you. Bye-bye.
Yeah. Bye, sir.
Thank you, sir.
Oh, thank you, Kundan. Thank you, Anil, sir.
Chalo, Nikhil, बढ़िया.